wonder of India.
Fantastic. We'll do so. Okay, I'm going to go mute until we start in 5 minutes. Thank you, everyone.
Yeah, I've allowed all the attendees to join in. People are joining in.
Hello, everyone. 3 minutes to go if we're going according to time. I just wanted to ask if anyone has any questions. And if they'd like me, or if they have any special requests to me, you can mention them now, or you can just send them in the chat.
So I'm sharing my screen for the introductions presentation that we prepared.
Okay. Looks good.
So I'll just quickly go through the series of the sequence.
Mm-hmm.
So we are introducing the university, the series, JSPH. Introduce the panels, or introduce the moderator, the panelists, followed by the second panelist, and the guests. That's in the sequence of the WhatsApp message that we have received. Then finally the lecture. So we would be going live. Hello everyone, good morning, good evening. I'm Rahul and I'm the co-founder and director at Purnima University and Purnima Group. I would like to welcome you all on our sixth webisode, that is from AIDS to COVID, the rocky road of public health. And before starting, I would like to give you a brief information about Poornima University, which was started in the year 2012. And it's a full-fledged private university in Jaipur. And we started the School of Public Health 1 year back in association with Jodhpur School of Public Health. But our our roots are common. We are based out of Jodhpur, and Anil sir and most of us are from Jodhpur. So it was 2 years back. Then I met Anil sir, and we started, thinking about starting Jodhpur School of Public Health in Jaipur. So here we are. We are offering bachelor's and master's courses in public health and hospital administration. And we have around 3,000 students in the university. I'll just quickly go through. So university is located in Jaipur in an area of around 32 acres. We have roughly 3,000 students in the university and around 7,000 students in the group. We are majorly into engineering, architecture, fashion, interiors, management, commerce, and allied areas. And as I said, we started public health a year back. I would like to introduce Dr. Anil Purohit, who is the founder and CEO of JSPH. And Dr. Anil has over 30 years of experience in establishing and running HIV AIDS programs in Africa, Asia Pacific, North America, and West Indies. He sits on various boards, including the stem cell IVF programs, technology companies, and academic centers. He has worked at Harvard Medical School, WHO, and US government's Department of Health and Human Services, among the other institutions. Dr. Anil has also worked for FXB as the Global AIDS Director and as Executive Director of FXB USA and India, establishing 44 plus AIDS program. Anil sir has also presented, authored, co-authored over 100 studies globally, and has also served as the advisor to the World Economic Forum, helping initiate the AIDS in India and AIDS in China, among the other programs. He has been a recipient of grants from Bill and Melinda Gates Foundation, Tata Trust, World AIDS Foundation, among the other agencies. So I'm really looking forward to this webisode, the sixth webisode in the series. And I'm sure there will be a lot of takeaways. Over to you, Anil sir.
Thank you very much, Rahul. It's a privilege to be here, and thank you all for showing up on Saturday morning, afternoon, and late evening, especially Marina. It's 9 p.m. in Malaysia. Before I start, I've got a couple of housekeeping announcements to make for all of us and for the audience and the viewers around the world. This is totally an academic community and service for the citizens of the world. People here on this panel are all committed. There is no incentive, monetary benefit. It is a commitment. And the reason they are here, because they want to do good for the world. And we do not take any support from the pharmaceutical companies, drug companies, alcohol companies, tobacco companies, and there is no child labor involved. And I think it's very important for me to make this announcement because some of us are civil servants, some are working for the United Nations system, and some of organizations require this. So I just want to be very clear to the viewers, the panelists, and everybody. And thank you, Rahul. Rahul is a wonderful person to work with, very young, energetic, open to technology, public health, new initiatives. His focus is always to reach to difficult to reach population, empower children, empower forgotten people. And it's been great journey for last 1 year working with Rahul, and we hope to take this forward. Very briefly, I'll tell you about JSPH, it's the Jodhpur School of Public Health. Being a student in Boston at Northeastern and Harvard undergrad, before going to medical school, always came to India or traveled to Africa to do public health in the field. And I always wondered why we don't have public health schools in India. There's only one in Kolkata, which is All India School of Hygiene and Tropical Medicine. And that's only for clinicians or doctors. So when I was working on my thesis and also working part-time for FXP, we were driving from Sumerpur, rural Rajasthan, to urban in Jodhpur with my former boss, the Countess, and we had funding from Gates, Bill and Melinda Gates Foundation, and it was on migrant health, HIV, and the first grant which came to us in India in 1999. So we were discussing 1.3 billion population, no schools of public health, and she said, "Let's start that." So we started putting $15,000 a year aside. Did that for a couple of years. Did a lot of exploration, and somehow we had a split, and we still work together. But I don't work as an employee for her, and coming to that, I and Dr. Arvind Mathur, who's on this panel, around 1:30 in the morning at the HIV clinic where he was seeing patients, we decided to start School of Public Health with tuition, totally tuition based. And the tuition was around $4,000 for 2 years. And we got a lot of applications from Afghanistan. And I'm very thankful to the government of Afghanistan. And today they are partnering with us on this webisode. And we started with 4 students, and so far working with the universities at Maulana Azad and the Jodhpur School of Public Health at JNU, and now at Poornima, we've conferred around 470 MPH degrees. So it's total commitment, passion, and most of my faculty initially came from the United States to India on the sabbatical, and some also from my employment place with permission from HHS in the United States. And this is where we are today. And I'm so thankful to all of you. And the objective for this webisode or webinar is at the School of Public Health, we do commemorate or we observe several health days, but in these unprecedented times, it was not possible. So around 31st May, we decided on No Tobacco Day to start these webinars. And then we did some global health with technology. And today we are on this COVID-19, which is, I think, on everybody's mind, everybody's living room, dining table. Where do we go from here? And we got all these experts here, founders of public health in India, the world authorities like Dr. Tom Frieden, Jonathan Quick, Marina, who's done wonderful work on HIV/AIDS. So I could name all of you, but I think you all are committed people. And my message to all is that the way we will go forward is, I always recall the US President, our 42nd US President, Bill Clinton, at the Retrovirus Conference in Boston said, whatever we do in HIV/AIDS is going to be in the history of books. It will not be in our veins or arteries or blood vessels. And our children will read. And we hope with AIDS, we will make COVID-19 a history. And going forward, I think we all will work together. The goal is same. And I'm very glad that MIT has partnered with us for COVID-19 India Challenge. And we'll be hearing about that too. So thank you all. It's a privilege. And I'm really honored. And I think I'm the most luckiest person to be here today hosting all of you with Rahul. Thank you. Over to Roy, the moderator, Roy Wadia and Veronica. Thank you so much.
Good. Yes. Hi there. Good evening from Bangkok, where it's about 8:08. And I want to say a huge hello to all the participants and the entire spectrum of the audience joining us from multiple time zones around the world. It is wonderful for me personally to be reconnected with the Jodhpur School of Public Health. It's been 5.5 to 6 years now since I was last connected. And it's also wonderful for me to be connected to my co-moderator, one of my very good friends and a former colleague from CNN days, Veronica Pedrosa. Over to you, Veronica.
Thanks very much indeed, Roy. It is indeed a pleasure to be working with you again and to be working with all our esteemed panelists. We have a very full program for the next 2 hours, and we want to include the voices of people right across the spectrum because we have them all available for you today. So I really hope for your patience and for your maintained interest throughout the 2 hours. And one of the ways that we're trying to do this is by, I'm afraid, being a little strict with times for each of our panelists, who will be speaking according to certain themes that we are going to pursue. First of all, we'll have 3 speakers speaking about what we've called the big picture. In a moment, I'll introduce you to you properly, Dr. Tom Frieden. Also, JVR Prasada Rao and Marina Mahathir will be speaking from Kuala Lumpur. After that, we'll have some more time to discuss the theme of, quote, playing detective. Where did COVID-19 come from? where will it go, and what are the data telling us? And we'll have 5 panelists speaking on that theme. After that, we'll talk about when worlds collide, the professional and the personal. And we're very lucky indeed to be able to speak to 2 clinicians who have been diagnosed and infected with COVID-19 themselves and who continue to work. In fact, I believe they're on call as we speak. And then our final topic will be the biggest global challenge since World War II. That's a quote from the United Nations Secretary General Antonio Guterres. Governments and societies respond. And we'll have another 5 panelists speaking to that. So again, I'm going to ask for your patience and forbearance as we try to get through a lot of material over the next 2 hours. Without further ado, may I now introduce to you our first speaker, who really is in a unique position of distinction to speak about the big picture, as I've called it. Tom Frieden is, I just lost my full screen there, is the leader, the CEO of Resolve to Save Lives. It's a global non-profit initiative funded by the Bloomberg Philanthropies, the Chan Zuckerberg Initiative, and the Bill and Melinda Gates Foundation, and part of the global public health organization, Vital Strategies. Dr. Frieden is, of course, also the former director of the US Centers of Disease Control and Prevention and former commissioner of the New York City Health Department. I suspect he's had a very, very busy few months since the beginning of the year. Dr. Frieden also would like me to mention that he lived in India for several years and that he holds India and the people of India very close to his heart. Over to you, Dr. Frieden.
Thank you so much, and it's great to be with you this evening, this afternoon, this morning. Greetings from Brooklyn, New York, where I live, and our offices for our global work at Resolve, where we work in nearly 100 countries, are based here in New York City. And really, over the last 6 months, we have, for the first time, begun working in the US, because the US has become one of the epicenters of the COVID pandemic. I'll stick to time, so go quickly through a series of slides and a series of concepts. As I think we all know, COVID-19 is not just a short, but also a long-term threat to public health. It's the most disruptive threat from infectious disease that the world has faced in a century. And the risk of explosive spread is going to be here until there's a safe and effective vaccine, which could be months or years. And the risk will not end with a vaccine, which is unlikely to be perfectly protective for life. Places around the world that have been guided by and fully supported public health have had less disease, less death, and less economic devastation. Important reality of COVID is that for those who are over 60 or with underlying health conditions, it is behaving like the 1918 flu pandemic, very severe and very transmissible. For children 0 to 19, it's behaving more like a mild to moderate flu season, quite transmissible, but not very severe, except in rare cases. This is very unusual. And of course, for those in between, it's right in between. That has real implications. The age structure of society, for example, will be a major determinant of the infection fatality ratio, which may be dramatically lower in India than in Europe, for example, simply because there are fewer people proportionately above age 60 and with underlying health problems. And I'm sorry to say that the pandemic is just beginning. It's affected virtually every country, and many countries, including my own, the United States, it is not being controlled. There's a comprehensive response needed to reduce spread, stop cases and clusters, use data to drive progress, and protect ongoing healthcare, something that's particularly important in lower and middle income countries, where the interruption of healthcare can result in large and devastating outbreaks of infectious diseases and big increases in AIDS, TB, and malaria deaths. This is a public health emergency, and public health must guide us forward. That means funding, approach, metrics, and messaging. Surveillance, including trends in excess mortality, is critically important. Smart, more nuanced restarting based on risk, outdoors versus indoors, group size, mask use, a box-it-in approach, and global solidarity. We have to transcend false dichotomies. It's not about closed versus open. We were never fully closed, and we won't be fully open until, in fact, even after there's a safe, effective, accessible vaccine. It's more like a dimmer dial, not an on-off switch. And it's not about health versus the economy. Economic downturn is deadly, and we can only protect lives by protecting livelihoods. Public health is not getting in the way of economic recovery. Public health is the road to economic recovery. Nor is it a question of this being either overblown or catastrophic. It's a severe pandemic, especially in older people with medical vulnerabilities, but it causes mild or no illness in most children and many others. There are two arms of an effective response. Start safer with the 3 W's. Wear a mask, wash or sanitize your hands, and watch your distance. And second, box the virus in. The 3 W's are extremely important, but they're not enough. One thing that we have to learn, and I would say the US has not been good at this at learning, is there's no one answer to COVID. Not travel bans, not staying home, not testing, not contact tracing, not wearing a mask, not even a vaccine. We need to chip away at this pandemic and make steady progress. Masks are very important. Anytime you're indoors near others outside of your home, anytime you're outdoors when you can't stay 6 feet from others, and at home if you're not feeling well and others are near, but not if you're outside more than 6 feet from others, or in your home if you don't feel sick in most situations. This is what we recommend as the box it in approach. Test widely and strategically so that you can know where the virus is. Quickly isolate all infected people. And around the world, the best cases are providing that isolation outside of multi-generational homes because of the great risk of spread within those homes. Contact trace and warn those who are exposed and quarantine contacts for 14 days. That means we have to reduce the time from infectivity to isolation, warn contacts promptly so they're quarantined before they become infectious so the virus can stop with them, and figure out how to provide safe, acceptable, temporary housing to cases and contacts where necessary to prevent household spread. This one slide summarizes experience from around the world with supporting isolation for both cases and contacts, with care packages, resources, and even financial support, masks, thermometers, food, laundry, medication delivery, health education, connection with the internet, a hand sanitizer, cleaners, and daily check-ins, instructions on how to keep the place clean, a hotline, garbage removal if needed, access to telehealth and relocation if requested. And the best places in the world have provided a stipend for those. Otherwise, they're going to go to work and they're going to infect others. The hierarchy of controls is very important. We have to do much better all over the world protecting our healthcare workers. This means elimination, substitution, engineering, administrative, and PPE. All of those are important. Source control means mitigation of the source to prevent transmission. That includes mask wearing. That includes keeping unnecessary visitors out. That includes providing telemedicine to people so that they can get care at home without coming in. Engineering and environmental controls, opening windows, increasing ventilation, replacing high-touch equipment, physical barriers like plexiglass screens, and redirect walking traffic to be one way. Administrative controls to reduce occupancy, stagger shifts, allow remote work, and eliminate break rooms, which has been the location of a lot of spread in hospitals. And of course, protective equipment, especially reusable face shields and reusable respirators. Children are much less likely to become ill, much less likely to experience severe illness. They may or may not be less likely to become infected. If you look at the evidence, it's different from different parts of the world, and they may be less likely to spread infection, but we don't know that yet. For schools, it's so important to shield the vulnerable, reduce risk whenever possible, keep the virus out, reduce occupancy, especially indoors, reduce mixing among students and staff, to mask up, have new safety protocols, and prepare for cases, because despite precautions, there will inevitably be cases, and the schools have to be able to continue with their work to the extent possible when that happens. Responding well can prevent large outbreaks. In the big picture, for all institutions, the challenge is keep it out, find it fast, stop it soon. Those three things: keep the virus out, find it fast if it's spreading, and stop it soon if it begins to spread. One best practice from around the world, including places like South Africa, New Zealand, Singapore, are alert level systems that empower the public, increase accountability, and accelerate progress. This is one example that we think is a best practice. 4 levels: very high risk, moderate risk, new normal. And in these, there are specific measures in each of what will be done. Healthcare in the context of COVID-19 needs to transform itself. We need to improve infection prevention and control, reduce the risk of treatment interruption, and innovate, including 90 and 180-day prescriptions, medication delivery to the doorstep, as the excellent Indian program on hypertension is doing, increase telemedicine, as India is also undertaking, strengthen primary care, including team-based care, and treat in community, including primary care instead of hospitals. So the health and wellness initiative is extremely important in order to decentralize care and bring it closer to the patients. Last slide, the bottom line: 5 steps to stop COVID-19. First, test. You can't fight what you can't see. And what we're finding around the world is the percent positive correlates pretty well with the incidence. And so it's a simple way, back of the envelope way of seeing how the epidemic is doing. But a test is only useful if you take action, if it's positive, by tracing, isolate, and quarantine. And whatever you do for a long time, we're going to have to avoid large gatherings, particularly indoors. Mask up. In East Asia, this has been the tradition for a long time, and now scientific evidence supports that masks reduce spread and they're low cost. But we shouldn't expect that if we can just mask up, we can all go back to normal. We're going to have to do a series of things to adapt to the new normal. Increase access to oxygen. Many lives can be saved by this. It turns out that ventilators, not so much in terms of the benefit of lives saved, but oxygen quite substantially. Protect healthcare workers, healthcare, and essential economic activities. Otherwise, in many parts of the world, particularly in Africa and parts of Asia, many more lives will be lost because of COVID disruption than because of COVID infection. So I'll stop there. I'm honored to be with you now. Our group, Resolve to Save Lives, works in countries around the world on both epidemic prevention and cardiovascular health. And we're honored to be part of this today. Thank you.
Thank you very much indeed, Dr. Frieden, and especially for keeping to time, although I might be infringing my own rule, because I would like to ask you a question. It's such a rare opportunity to be able to ask someone of your distinction and experience about COVID, that I feel it would be remiss of me not to ask you about the political maelstrom that the US finds itself in its approach to public health. And it's something that I think, well, I hope that you'd be willing to speak to, given the range of your experience from what's going on at the moment. And I understand that you were with the CDC during a very different time. Dr. Frieden, if I could ask you to address the differences and about the politicization of public health. Can you hear me, Dr. Frieden? Hello, Dr. Frieden, can you hear me? Can I ask our tech people, is he able to hear me?
No, actually,
The screen is
yeah, even the screen is, we can move ahead with the
All
next
right,
speaker.
that's a shame. Over to you, Roy.
Thank you, and we hope to get Dr. Frieden back if that is at all possible technically. So, as you know, the webinar is called From HIV AIDS to COVID-19. So let's go back in time to a very different crisis, but also one with certain similarities to the pandemic, and that is, of course, HIV and AIDS, which has been around with us, as far as we know, for more than 4 decades now. And so the next speaker is someone who really needs no introduction, but I will introduce him anyway. And he's my good friend, JVR Prasada Rao, who, as you may know, has transformed HIV/AIDS response, not only in his country, India, where he was in charge of the National AIDS Control Organization way back when, and he truly transformed that into a much more open and much more proactive entity. And he really opened the doors to inclusion of people with HIV in the strategy to end HIV. And then he, of course, transformed HIV response in Asia and the Pacific when he was in charge of the UN AIDS Office for Asia and the Pacific for, I think, several years. And then after that, he was the special envoy of the Secretary General on HIV in AIDS in the Asia and Pacific theater. So Prasada, turning to you and from your vast perspective, looking back in time and looking forward and seeing where we are right now, have governments and people learned any lessons from the past, and what are those lessons that are being applied now from your perspective? We also see that despite having had pandemics in the past, despite HIV and TB and other big ticket items, many countries, developing countries in particular, still don't appear to prioritize public health and pandemic preparedness. So why is this, do you think, and what are your thoughts about this? Over to you.
Thank you, Roy, for that introduction. Good evening, everyone. While the world is grappling with a runaway epidemic of COVID-19, which is defying all projections on its progress, it is time to take a hard look at the reasons for the collective failure of governments and to check its spread. I think that way what you said, Roy, is very topical. So it is AIDS to COVID. First, let us rewind to the 90s and recollect how the HIV AIDS epidemic, which was threatening to overwhelm the countries at the time, was finally brought under some check in both incidence and mortality. I'm not saying that it has been effectively controlled. I feel it is slipping out of our hands because of political ineptitude and lack of commitment. But here, I want to highlight how the global AIDS response was successful in adopting a public health model to halt its spread and brought into focus the importance of public health in containing spread of communicable and non-communicable diseases. Here, public health should not be understood as, in a narrow sense, as public sector health. It has a wider connotation and should essentially have 4 distinct characteristics, according to me. First is prevention. Prevention should be the key. It should be in the forefront of disease control and other health interventions. And populations who are most vulnerable and at risk of contracting the infection should be central to the response. Second is treatment. Treatment programs should be carried out at the lowest level of primary health care with emphasis on awareness, counseling, and follow-up. Third is civil society involvement. I think civil society should be a very strong partner with governments in policy and also implementation. And finally, national and global responses should be evidence-based. Strong and focused epidemiology should drive programs. Now, I would like to call them the 4 pillars of a public health approach. And it is not just for control of epidemics only, but health interventions in general. Since the onset of AIDS, the world has witnessed emergence of many new viruses which took the form of global and local epidemics in the last 2 decades. We have SARS, Ebola, H5N1, H1N1 are very prominent in this list. But all of them took the world by surprise and exposed the weakness of the health system and lack of preparedness of countries and UN agencies like WHO to quickly mount an effective response. The responses were mostly biomedical in nature, and we did not see any of the approaches I explained earlier adopted for their containment. No lessons were learned on how a people-centered approach could have minimized the damage in terms of morbidity and mortality. And this happened again in COVID, which has completely thrown the system out of gear in a short period of 6 months. We are just chasing the epidemic, and we are nowhere near getting ahead of the curve. And in very few countries do we see a successful application of the sound public health principles I spoke about earlier. First, let us take prevention. Prevention focus in COVID has to be around universal use of masks and social distancing, as Tom pointed out. But we see that shortage of good quality masks and lack of awareness around social distancing are the basic causes for the explosive rise in new infections. And we don't see people's involvement in getting these messages across. On the contrary, we see anti-mask campaigns in US, which are hard to explain. It exposes the failure of public health programs and reaching the message of prevention to the people. Second, in treatment, COVID treatment today is highly centralized in tertiary care hospitals, which are branded as COVID hospitals, and no facilities exist at primary healthcare level, resulting in migration of people to urban areas in search of treatment. Failure of governments in strengthening systems of primary healthcare has been seriously exposed in this COVID crisis. We hear about so many instances of patients brought to COVID hospitals facing refusal of admission or getting a late stage, leading to a higher level of mortality. And the poor and the underprivileged are the biggest sufferers. Third is the entire response is government-driven and enforced. Police and law and order machinery have been brought into the picture for enforcement of lockdowns and closures without any involvement of local communities. There is a conscious roadblock to participation of civil society and communities which are most vulnerable to the infection. For example, the involvement of COVID warriors in countering stigma and generating awareness has been minimal, unlike that of HIV positive networks, which were seen in AIDS programs, which were very, very actively involved. But most importantly, the national responses are not driven by sound epidemiological evidence. Barring a few exceptions, we do not have a credible estimate of COVID prevalence in many countries. We all know that the actual infection load will be several times higher than the reported or confirmed case load. But we, country and global leadership, in a denial mode to bite the bullet, to make the people aware of the high percentage of population who are already infected with the virus. So the question is whether public health, where is public health in COVID response? And in all these years of regular onslaught of new and deadly viruses since HIV, every time exposing serious deficiencies in our approach to disease forecasting, prevention. The reasons are not difficult to find. For many governments in the developing world, health is synonymous with medical care. Health policies world over promise higher investments in primary health care, but this doesn't happen in practice. Prevention and health promotion with strong focus on hygiene and nutrition do not figure high in the government priorities. If you take countries in Southeast Asia, they owe their success in containing the epidemic to their investment over the last few decades on promoting sound public health practices like public and personal hygiene among the people. But the big difference is absence of community involvement at every level of COVID response. In conclusion to 2001, we had great leadership at global level within countries and UN organizations like UN AIDS, who inspired the country leadership for launching an effective global AIDS program. Great institutions like Global Fund and PEPFAR came up within a very short period of time to provide the billions which made the difference. Do we have leadership today to take charge of COVID response? There was no meeting of minds even for adoption of a Security Council resolution on COVID, which could have helped in raising the visibility and the underlying security implications of an unchecked COVID epidemic. While there are many areas where global action is found wanting, for me, the most glaring of all is the failure of leadership. It is the big difference in the rocky drive of public health from AIDS to COVID. Thank you.
Thank you so much, Prasada. One very quick follow-up, and you actually spoke about this just now, but if you can maybe expand from your thinking, from all the accumulated experience you have, how do we get this political will? How do we actually generate it at a time when the world seems to be more fractured than it has ever been?
I think it needs to happen both at the top as well as at the grassroots level. We need global leaders. We need global leaders who can enthuse, who can bring people together and then talk about this, like what we did, as I said, what we did in AIDS. But more than that, we need that pressure from below. There's no pressure on the leadership right now from the people, from the communities, as to what to do, how to act. And this, when you say community, it involves all the actors. I think these are the two things which are seriously lacking in the COVID response. We find which is entirely an enforcement-oriented and a completely government-driven program and completely medicalized type of response. I think that's the big difference between what I see in the AIDS response and the COVID response.
Thank you so much for that. And so now back to you, Veronica. I think we've got Dr. Tom Frieden back.
Yes, we do indeed. Thank you to the technical gods for that. Dr. Tom Frieden is back. So Dr. Frieden, if I might ask you about actually the same theme as what Prasada Rao was discussing just then with Roy, the politicization in the US context of public health matters?
Well, I have to say what we're seeing in the US is unprecedented. The US Centers for Disease Control and Prevention has existed for nearly 75 years. And in every prior health emergency, it has been front and center in the response, both at the decision-making table and at the podium explaining it. And a large part of the failed US response is because of a failure to follow public health principles. We do find in parts of the country, and as in India, in the US, health is a state affair, but it's crucially important that the central government get it right. And in the US, what's really stunning is 6 months in, we have no clear leadership, no clear plan, no accountability, no shared metrics, no standard approach, no vision. It's really striking. And I can't explain why that is the case. I'm not in the government now. I can just say that it's quite unlike anything that's happened before. I fear that public health entities will be in the unenviable position of being seen as having failed, when in fact the failure was of the political leaders to trust and support public health. And when we look around the world, we see that responses that, as Prasada Rao, and it's very nice to see you again, we worked together in India, as Prasada Rao says, responses that trust and rely on and engage communities, responses that are organized, that are based on data, that learn continuously and understand that there's a lot we still don't know. And as we learn more, we're going to adapt our response. We'll see what a vaccine can do. We'll see what different treatments can do. We're learning more all of the time, but that's not a failure, that's a success. And as we learn more, we apply it. One of the great challenges is this misperception that public health is getting in the way of economic growth and recovery. And that's simply wrong. Public health is the road to economic growth and recovery. And you can see that in countries around the world that have used the public health approach and are getting their economies back. That means that we do have to physically distance. I don't like the term social distancing. We need to be socially united, but physically apart. We also need to use masks, use strategic testing, contact tracing, isolation, and figure out ways carefully that we can restart essential parts of our economy, including schooling to the extent possible, and being able to do that out of doors wherever possible is immensely safer than indoors. The old tradition of teaching under a tree has a lot going for it these days. We have to adapt our society using public health principles to protect our economy and society so that we can continue to grow and save lives.
Thank you very much indeed. A very cogent answer. It really kind of joins up all these different spheres that I feel have been silo-ized as a way of administering different issues, but which need to be joined up nowadays. Thank you, Dr. Frieden. Thank you, Dr. Frieden. I would like now to introduce our next speaker, who again is someone who needs no introduction. I understand that that Marina Mahathir was named the UN Person of the Year by the United Nations in Malaysia. But she was also, but to my mind, I think of her as someone who has been at the forefront of bringing the voices in Southeast Asia of marginalized people. We haven't spoken much about women in the discussion so far and where they stand in the public health matrix, as it were. She's also a writer, but mostly a women's rights and HIV AIDS activist. She served as president of the Malaysian AIDS Council for 12 years. And I wonder, with your experience also as on the board of the Sisters in Islam, which advocates for justice and equality for Muslim women, how, with your particular and unique kind of experience across these different perspectives, you've approached COVID. We've described your talk as being about the lessons of HIV, COVID-19 and politics, but I hope you can bring in those aspects as well. Thank you.
Thank you, Veronica, and good evening, everyone from Kuala Lumpur. It's very nice to be here. Thank you so much for inviting me. I guess I will mostly talk about the experience of Malaysia with the COVID-19 pandemic, which I hope will complement the previous two speakers. I wasn't particularly going to talk about women, but I can certainly add that in, Veronica, because I do know quite a bit about that too. But anyway, just to give you the picture for Malaysia right now, Malaysia's population is about 32 million people. And as of today, there's been 9,070 cases in total since about February, I guess, and 125 deaths. 8,775 people have recovered. So we have a recovery rate of 96.3%. And daily cases are between right now 1 and 25. Like today was only 7. And we did have one day with no new cases at all. But lately there has been a cluster in a district up north, stemming from a man who returned from India, I'm sorry to say, who didn't finish his 2-week quarantine period and then open his restaurant, which apparently is quite popular, because due to that, he has been found to have infected at least 43 others, some of whom have traveled to other states. I'll come back to that in a while. But overall, Malaysia's management of COVID-19 has been pretty good, I would say. The country went into what we call Movement Control Order, or MCO, on March 18, originally for 2 weeks, but then it was extended in 2-week increments until we loosened a bit with what we call a conditional MCO. And then on June 10th, we went into recovery MCO, which is the phase that we are in now, which means that offices and shops and schools are open, but with, of course, the usual SOPs, we call them, masks, washing hands, physical distancing, and all that. But, you know, at any time, should the numbers increase, we can revert back to the original stricter MCOs, but perhaps more in local areas, such as the case that I just talked about. We should note that all this has happened against a backdrop of basically a coup that led to an unelected government now in place in Malaysia. At the end of February this year, the previous government collapsed due to some MPs crossing over to what was then the opposition and then claiming that they had the majority in parliament and therefore formed the new government on March 1st. And straight after that, they had to deal with the COVID-19 pandemic. But despite this political upheaval and ongoing political issues and instability, I think we've had a very steady hand in the management of the pandemic, because it's all been in the hands of our Director General of Health, Dr. Nur Hisham, who is, of course, a health professional, so at least knows what he's talking about. From my experience in HIV all that time ago, I recognize a lot of what Mr. Rao and Dr. Frieden said. There are similarities and differences with the COVID pandemic. I think in both cases, anyone can be at risk if they have no information about the virus, right? In Malaysia's case, information became widespread very quickly through all media, including social media, in all the major Malaysian languages. So people got it really fast. The Director General gives daily briefings up until today on TV, and people do tune in. At 5 o'clock, they know he's on, and people tune in. And apart from the first week or so, the Minister of Health, who's a politician, has not interfered at all. However, as we know, the virus does not discriminate, but people do. There was a serious lack of information in languages that are understood by migrant workers and refugees. And so this had to be filled in by NGOs who, of course, do not have the coverage that, you know, the mainstream media has. We have about at least 1 million migrant workers in Malaysia, and about a few 100,000 refugees in the country. So they're a very underserved population. Another difference is that because people felt that COVID-19 can infect anyone, compliance to social distancing and what is known as standard operating procedures has been pretty good. While we cannot know if everyone who needs to uses condom to prevent HIV, we do know if people use masks and gloves and disinfectants and in the public sphere, because we can see normally. For instance, we cannot enter any malls or supermarkets without wearing a mask, having our temperatures taken, or using sanitizer on our hands. It's a pain, it's a hassle, but it is done very strictly everywhere we go. At every outlet, we have to scan a QR code that links to a government contact tracing app. For those who are a bit paranoid about data, this is a problem. Or to write down our names and phone numbers on a list that the shop or the restaurant provides. And you can't even enter without doing this. But although compliance is generally high, there's still an issue of people not using the mask properly, or sometimes even not wearing. There are, some people who are still a bit stubborn. It's not out of an insistence on individual rights as in the US, but just because it's uncomfortable. It's hot, uncomfortable, and so people pull it down and put it under their chin, that sort of thing. As a result, and this is the government approach, you hit hard on people, there's now a ruling that masks are compulsory in public places, and if you don't, you have a very heavy fine of 1,000 ringgit if you don't wear one.
I have to ask you to wrap it up just because of other speakers coming.
Sure. I still have a lot more, but I think I just want to make 2 points. One is about migrant workers and refugees. They have been a neglected population, and unfortunately, this is where the political situation has come in, with the government using the opportunity often of isolating migrant populations who live in very cramped quarters under the pretext of COVID, and then cutting them off into immigration detention centers, which are very cramped and very crowded. And that has created this idea that they are responsible for spreading. We have had some boat landings by Rohingya refugees, and although we have been very welcoming before, this time it's not been the case. As far as women, of course, like many other places, the number of domestic violence cases has increased. Applications for divorce has increased. Government's first reaction was to actually close down hotlines because everyone's supposed to work from home. But after a lot of protests, they put it up again. And of course, the NGO hotlines have been very, very busy. There has been a real lack of gender perspective in the response. And women have really suffered, not just in terms of that physical violence, abuse, lack of access to help, etc., but also in terms of income, because so many women are in the informal sector, which of course relies on customers, and now they don't have it. And not everybody could convert to online business. So, okay, I'll stop there and see if there are any questions.
Thank you very much indeed. I would love to ask you a question at this point. Part of the reason, though, that we're having to move on rather rapidly to the next part is because our next speaker has to leave at the top of the hour, so that's why.
No worries.
So we'll come back to you a bit later if you can stay. I know it's very late in KL, so I want to say thank you very, very much indeed. Your participation's much appreciated, and thank you for speaking to the women's perspective.
No worries.
The next section of our discussion, our webinar, is Playing Detective. Where did COVID-19 come from? Where will it go? And what are the data telling us? Our next speaker is Dr. Leo Anthony Celli, who's speaking about what the COVID-19 data tsunami is telling policymakers. He's an internist, an intensivist, and an infectious disease specialist who's practiced medicine in 3 continents. And he is somebody who is able to speak about all of the kind of digital health aspects of the COVID-19 pandemic. Thank you very much indeed, Doctor. I believe that we have a good 10 minutes with you, I hope, before you leave.
Hello, greetings from Boston. I do have some slides, but I think I'm gonna skip the slides just for the sake of time. As you have mentioned, I work in the intensive care unit at Beth Israel Deaconess Medical Center, one of the Boston area hospitals. And I represent a consortium, a global consortium called MIT Critical Data. And we consist of healthcare practitioners, computer scientists, engineers, social scientists, whose mission is to put data and learning at the front and center of healthcare. We believe that those two, data and learning, are the best medicine for this pandemic. We create communities across disciplines to derive knowledge from data routinely collected in the process of care in order to understand health and disease better at the local context. We are also invested in training the next generation of clinicians and computer scientists to leverage the knowledge encrypted in electronic health records. We had written a book in 2016. It's called Secondary Analysis of Electronic Health Records. And in the true spirit of MIT, we have made the digital version of that book completely free of cost. And I'm happy to announce that we just published our third textbook. It's called Leveraging Data Science for Global Health. And with funding from MIT libraries, the digital copy of the book is also available for free. In this book, we contend that the most daunting global health issues right now are the result of interconnected crises, global warming, the pandemic, systemic racism. And in this book, we highlight the importance of a multidisciplinary and community-centered approach to data science. As I said earlier, data and learning should be the centerpiece of global health. Every patient encounter is an opportunity that we could learn from, and every healthcare provider should be a contributor and a custodian and not merely a passive recipient of the medical knowledge system. Going and diving into the pandemic, I'm gonna go back 102 years ago. There was an article in the New York Times dated September 14, 1918. And in that article, it quoted the Surgeon General at that point, Dr. Rupert Blue, and he touted that this anti-malarial drug quinine is being used by other doctors to treat the pandemic flu. And this was back in 1918. And there was no evidence that quinine works for the pandemic flu, but the doctors were desperate and they were willing to try just about anything. And so they did. They would eventually abandon the use of the anti-malarial drug quinine for the treatment of pandemic when there was no evidence that it was effective. And also there was some suggestion that it was serious, it could cause serious side effects. So this shows you that as humans, we haven't learned anything in the last 102 years. We have exactly the same situation right now with the hype around hydroxychloroquine. In the first few weeks of the pandemic, knowledge about the disease and its treatment was generated from sharing of anecdotal observations and small case series. And although healthcare professionals like us use modern technology to communicate, never before has the failure to build robust data sharing systems for large-scale, near real-time analysis in healthcare been more obvious. In an editorial that we published at the start of the pandemic, we posed the question, where are the pooled patient-level data? The failing is not really rooted in the absence of technology or precedent. Our group has made publicly available to the research community several electronic health record databases which have been de-identified. One of them is called MIMIC, and it's an evidence of the possibility of data sharing beyond the walls of Beth Israel Deaconess Medical Center, which is the hospital where our data comes from. This similar type of a database of ICU patients with COVID-19 from around the world is in the works, and it will contain every information that has been collected from patients who were admitted to the ICU coming from several countries. One of the projects that our team is working on combines computer vision applied to chest x-rays with traditional machine learning using clinical data. Can we predict if someone is gonna survive or die from COVID based on the chest x-ray taken on the day of hospitalization in combination with some of the clinical data that is captured from the patient? And are there patterns on the chest X-ray that we are not even aware of that could be linked with clinical outcomes? There has been tons and tons of papers on mortality prediction over time. Like even in the last decade alone, there are tens and thousands. And we expect that with COVID, we're going to see a steep rise in this particular field. But what does a mortality prediction mean? A significant number of hospitalized patients who die get admitted to the ICU. And for those who work in the ICU, we know that the vast majority of death follows cessation of treatments. And a lot of factors go into the decision with regard to whether the treatment should be continued, and including whether the outcome, if the patient were to survive, is aligned with the patient's preferences. So in essence, a hospital mortality prediction algorithm is actually predicting which patients will have their treatments discontinued. And it will only be accurate in the clinical context where the clinicians make predictions in a similar manner, where patients share the same values and preferences around quality of life, and where the decision-making process resembles that of the training cohort. We've read hundreds of mortality prediction models touting superior accuracy, but what does that actually mean for the patient? What does that mean for the providers? This level of understanding is important to assess the generalizability of any analysis of any model that uses hospital mortality as an outcome. And this is why it is crucial to have computer scientists and healthcare practitioners analyzing the data together and learning from each other. And finally, an unprecedented volume of academic literature has been produced since the start of the COVID pandemic. Much of the literature has been made available to the public at record speed on preprint servers or through expedited review at major journals. But more than ever, we have learned that medicine needs to incentivize good research practices. Standards of data sharing, standards of code sharing must evolve to publication policies and to encourage third parties to reproduce their studies. We published an editorial last year where we warned readers that the excitement around big data means that we will soon be drowning in publications touting sensational findings and models with near perfect accuracy that cannot be reproduced. The research economy cannot turn all its incentives towards novelty, emphasizing sensational results to generate attention and prestige. What is important is to make sure that we have a system that takes reproducibility seriously and incorporates voices who know how well-intentioned scientists can be led astray. And we've seen examples of that during the past few months. The health of the research environment will directly affect medicine's ability to improve the health of human beings. And with that, I'm gonna pass it back on to you, Veronica. Thank you.
Thanks very much indeed, Dr. Leo. You were extremely succinct, and I really appreciate your support for the whole webinar and for the insights that you brought then. I wonder if you can briefly address the question of what's the one single thing that you think could be done to make the data more useful to people around the world, available and useful around the world.
Yes, the biggest problem that we see in data sharing, people always think that it's the regulations, but for the most part, it's the culture. Our mindset are still stuck in the 20th century with investigators saying that this is our data, no one else should be able to publish off it, and there's no sharing of benefits from this data. And I think we need to change that. Lives are at stake, and also sharing the data tempers any temptation to fudge the numbers. If you know that someone else will try to replicate your analysis, I think you will kill off any temptation to try to come up with a p-value that you had determined at the start of your study, an AUC that you have intended to present to the audience.
Wonderful. Thank you very much for your, it's very succinct and very outspoken, not pulling your punches. Thank you, Dr. Leo Celli. Roy?
Thank you so much. Yeah, I mean, that was really fascinating. So, you know, as we've heard with the coronavirus story, there have been many conspiracy theories. Where did this come from? Was it man-made? Was it concocted in a lab? There have been some really wild stories there. But the fact is that most of these emerging infections, these viruses, do come from the animal kingdom. And so we have with us someone who is really legendary, I would say, in the field of public health, Dr. Srinath Reddy. He's in charge of the Public Health Foundation of India and has been for the last many, many years now. And he's also linked with the World Health Organization and many other entities. So, Dr. Srinath Reddy, over to you to explain where did this coronavirus come from, and from your perspective, what does it teach us at this time? Over to you, sir.
Thank you very much. I think if we pose the question, where did the virus come from? The answer could be from the forests of the night, where the bats and the pangolins and many others live in great harmony, including with the viruses which do not seem to harm some of those wild primary hosts. When we are talking about zoonotic pandemics or zoonotic infections, which transmit from animals to humans, we have 6 kinds of pathogens: viruses, bacteria, fungi, protists or protozoa, prions, for example, the one which caused the mad cow disease, and worms. But it is the viruses that are the most dangerous in terms of their ability. They are most threatening because they cross species very easily from the forest-dwelling animals to veterinary life and into human habitat, and can then multiply very fast. They're unaffected by antibiotics, but it is the spillover from species to species that makes them particularly dangerous, because once they get free access to a large population of animals or humans who are also fairly mobile, they can mutate and multiply very fast. They also have a great penchant for exchanging their genetic material with other viruses, and therefore that makes it even more difficult to pin down a virus once it is moving around freely in the human population. And we have seen many of these: H1N1, H5N1, SARS, MERS, Ebola, Nipah, and so on. But COVID-19, which is the novel virus that has entered now, is particularly a virulent form in terms of, particularly infectious in terms of its ability to move, though not as virulent as SARS or MERS, but certainly more virulent than some of the common cold coronaviruses. But where do these actually come from, and why do they actually come into the habitat of animals who are captive bred or the humans? It is because we have created conveyor belts for their transmission through deforestation, animal farming, and wet markets. And we are giving them a free pass to move around and mutate and multiply. And that is why the whole idea of surveillance has to link wildlife with the animal population and humans. And that is where the concept of One Health or eco-surveillance comes in. We cannot just track these viruses when they enter the human population and start moving around. We have to track them right from the very beginning if we want to prevent the pandemics. Indeed, if we are looking at farm animals, we're looking at not only the livestock, but also the poultry. And we are also having to link up of necessity with the wildlife. We have heard of the bat woman who has studied bats in caves in China. It's the kind of wildlife also that we need to look at if we want to contain. But containing in communities of origin in human and habitat is very important. We have to activate the farmers, the livestock owners, veterinary health services, health officials, and create a very quick data gathering system of early recognition of sick animals, their identification of potential pathogenic infection, and then try and ensure that it does not spread within that community or to the neighborhood communities. So establishing this eco-surveillance is absolutely critical, and not just depending upon surveillance of the pandemic or epidemic once it is broken into the human community. So what we require is a community-led, real-time, pre-spill disease monitoring system through local networks. And we've seen a good example of this established in Thailand, where with the help of the farmers and others involved in livestock, very quick identification of sick animals, information to veterinary doctors, as well as other health officials, brings a very quick containment of potential pandemic outbreak. And this, you can actually use our information technologies like social media, mobile phones, and other messaging platforms for very early alert systems. But that calls for also a more fundamental ecological response. We need to identify why deforestation is taking place at such a high level for farming and agriculture, for urban development, for mining, and then try and control the level of deforestation. We need to ensure our wet markets are controlled so that there is no communication between wild animals and other pet animals of veterinary population and humans. And our food and dietary habits have to change, but also fundamentally our food and agricultural systems will have to be recast. And then we also extend into the other areas of environment, because we now know that air pollution is damaging to lungs and to innate immunity, and a COVID virus can easily find a damaged lung much more attractive and can damage it much further. Therefore, when we are really talking about the environment, we are also bringing in the element of air pollution as well as the whole area of containing deforestation and ecological despoilation, so that we don't give a free pass to these viruses to move. To quote Joshua Lederberg, who actually in 1958 wrote, this is actually, he said he got the Nobel Prize for bacterial genetics. He said, it is our wits versus their genetics. And to quote David Quammen, who wrote on spillover, ecological circumstances provide the opportunity for spillover. Evolution seizes the opportunity, explores the possibilities, and helps convert the spillover into pandemics. We have to interrupt that cycle. But if we actually do it also by our response to the pandemic, by physical distancing, wearing masks, and not crowding, we are creating a bumpy road for the virus. We are not giving it an open highway to travel. And then evolutionary biology can force the virus to mutate back into a milder form so that it can continue to retain its species, so that its species is no longer extinct, because the limited human host becoming extinct also extinguishes the viral species. So we have to use even evolutionary biology, which has played in favor of the virus when it entered from the forests into the larger human or veterinary community, to also nudge it back to mutate into a milder form. But certainly, we need to look at the way our human society is dealing with the environment in a much more meaningful way. And in terms of surveillance systems, we need to create a robust One Health system with an integrated eco-surveillance from wildlife to veterinary population to human population, and detect when the infections start early and interrupt the chain of transmission. Thank you.
Thank you so much for that, Srinath. I just love the way that you took it all from the start. You brought it back, and you also incorporated all the important messaging that we heard from Tom and so many others so far. So with that, I would like to hand this over to Anil to actually introduce our next speaker. Anil, over to you.
Hi, sure. Thank you, Roy. I'd like to introduce you to Kushal Goyal. Kushal Goyal is from MIT, and MIT is running a COVID-19 challenge for India. And they have partnered with JSPH, and that's why you see the logo. And MIT has been working very hard on this COVID-19 for curbing it in India and other continents around the world. But I think it's the first time they're doing it for a specific country. And I would hand over to Kushal to give us more details and how we can help, because the goal is same. And we all are here because of COVID-19 and how we could all fight against that. So Kushal, over to you.
Thank you, Anilji. So just as a quick form of introduction, this is Kushal for my day job. I work at Excel International, and we are right now working on 100-odd COVID-19 clinical trials for vaccine. But the reason why I'm here, I'm going to switch hats, is to talk about the MIT COVID-19 challenge. And to do so, I'll just share my screen briefly. The MIT COVID-19 challenge is an, it's an all-volunteer effort. We've been hosting hosting hackathons since back in March. And as Anilji mentioned, we've done a few of these already, right? So we have done few focused on the overall pandemic spread more broadly. We have done one focused on Africa, one focused on Latin America. Dr. Leo was integrally involved in the Datathon one that we ran a few months ago. And our hope was, that we wouldn't have to run one for India, to be honest. But unfortunately, with the rising numbers, and as Dr. Rao was suggesting, the pandemic can only be cured if there is a response from the grassroots level. So the government is really trying its level best to, tackle COVID. But what we are hoping to do with the hackathon is to really energize the grassroots level to think about COVID. So the hackathon that we are focusing on India will broadly look at 4 areas. So we are going to have 10 tracks focused on strengthening the healthcare system, combating misinformation and fraud, helping the underserved population that will include migrants, slum dwellers, and then also the question of the informal economy, right? Because unlike some of the developed countries, there is not a lot of savings available for the local population in India. So hackathon is a very MIT term. So just to boil it down to layman's language, uh, hackathon is really about creating solutions to a problem over a 48 hour time frame. So right now we are in process of recruiting like-minded partners, including government, non-profit organizations. But the website will go live by Monday. And if I compare this to previous hackathons, we on average pull in around 1,500, 1,700 participants from 70 to 80 countries with 70 plus partner organization. And the idea is we'll give you all the resources that we have collected, both in terms of data, best practices. We'll give 10 kind of problem statements or 10 tracks where we are trying to find solution. And then the teams will co-form and then start working on the solution. And hopefully we would have created an ecosystem that would help sustain these ideas well past the hackathon. So we are recruiting for partners. The participant and mentor registration will go live by Monday. You can go to the website covid19challenge.mit.edu to register. But with that, I think those were my main messages. I'll hand it over to Veronica and Roy. Thank you.
Thank you very, very much indeed, Kushal Gohil. I'm glad I know what a hackathon is now. And thank you for the amazing initiative that you guys are taking on. I'm moving on now to our next speaker, who is a great supporter, from what I understand, of Dr. Anil's initiatives. Phyllis Kanki, her research centers on the virology, molecular epidemiology of HIV in Africa, along with implementation science work to improve HIV outcomes. She's worked a lot in Africa. And in response to the current SARS-CoV-2 pandemic, she's working on the development of antigen and antibody assays based on pan-subgroup 2B beta coronavirus and proteins that may serve as zoonotic surveillance tools for future emergent SARS-like viruses. I'm sorry, it's a bit technical there, but I'm sure that you can explain it. Over to you, Dr. Phyllis.
Thank you. It's a pleasure to be here. So maybe I could have my first slide. I just have a few of them. I was trying to address the question about where this virus was coming from and the origin. And as many of you know, this is a new virus from the family of coronaviruses, which are RNA viruses. They're single-stranded viruses. Could I have the first slide? Or should I share my screen?
I'm sharing a screen. I'm
Okay.
sharing it.
Okay, great. Thank you. So this just shows that the family of coronaviruses, as has already been mentioned by many, really comes from animals. The ancestor is largely for the mammalian species hosts the bats, of which there's millions of species, and they're found globally around the world, as well as birds. So there's four main groups, the alpha and betas that are primarily the mammalian species, and then the gamma and delta, which largely come from an avian ancestor. And you can see that there are a number of host species that end up as a result of spillover from the bats that carry a huge diversity of coronavirus genomes. And then we only begin to understand when they spill over. And so, as has already been mentioned, it's really critical for those of us in public health to think about how we can detect those spillover events before they occur. Now, not all of the spillover events result in a pandemic of serious disease. There's huge diversity in the type of disease. Many of the coronaviruses cause gastroenteric disease, and then others cause respiratory disease. And those are the sort of typical pathologies that you see. But it also ranges the gamut of a mild or less serious disease, like we have in the 4 human coronaviruses that are responsible in large part for the common cold that we see in many parts of the world on a seasonal basis. And then we have the more serious ones. So on the next slide, we talk about the more serious ones, the 2004 first SARS virus that also began in Asia, but then did spread in other parts, but were largely contained. It appears to be a less transmissible virus, is very closely related to the virus responsible for COVID-19, which we're now dealing with. Again, related to a bat virus. And then the MERS virus, which is a little more distant, more of a cousin virus. The intermediate host for the MERS virus, first recognized in the Middle East, is a camel. And we know that the camel, largely an asymptomatic spillover host species, and you can still find camels throughout the world that have antibodies and evidence of the virus infection. And then the individuals who are in close contact may also have evidence of that. MERS is a more fatal disease in certain populations. And then we have the COVID-19, which again has a unique presentation, predisposition for serious disease in certain racial groups, gender groups, age groups, and those with comorbidities. And pretty good evidence now that the intermediate host was probably the pangolin, potentially at the live markets. So I won't talk too much about the tests that we're developing. I'll just say that it's based on the concept that we believe that bats and the related viruses that they carry may be the group that we want to study when we think about developing a test for the next coronavirus that may be spilling over into human populations. And we're trying to develop a test that will be sort of the future test that can be used to detect new spillover events, both in animals, individuals who are in close contact with animals, or in populations that are in close contact to animals, et cetera. In response to the current outbreak, because I work primarily in West Africa, I've been very concerned about healthcare workers. and has been alluded to by many speakers, we recognize that healthcare workers are really at the front line. And globally, we recognize that countries with less developed health infrastructures, less PPE, et cetera, lower healthcare workforces will be at much higher risk for infection from patients as they present in these various healthcare settings. So we would like to develop surveillance systems, particularly in countries that may have a lower ability for large volume testing, and recognizing that this testing is a fairly complex laboratory test. And so there will be many countries that will not be able to scale up hundreds of thousands of tests per day. Recognizing that healthcare workers will be the first to be exposed to the virus, we want to develop testing that's focused on healthcare workers, not only to protect them because they're an important resource as we care for patients, but also as a little bit of a sentinel for where these populations will be and where the epidemic is in particular places.
I need to ask you to wrap up, Dr. Phyllis.
Okay, and then the final is just to take advantage of that so that we would be able to study secondary transmission from healthcare workers, the natural history and immunity that may be unique to those populations, and develop real-time health policy that can protect them and their patients. So thank you very much.
Thank you very much indeed, Dr. Phyllis. Over to you, Roy.
Thank you so much for that. So we've heard where the COVID-19 virus came from, and we've heard about the data. So now let's ask the question, where is it going? And more important, will it actually ever go away? So to help us answer that, we've got Dr. Jonathan D. Quick, who is also known as Jono. He is a world-famous global health leader, and he's the author of the book, The End of Epidemics, the looming threat to humanity and how to stop it. So, Jono, over to you.
Okay, thanks very much, Roy. Thank you to Anil for inviting me in today, and to all the organizers. Let me just share my screen here. Is this coming through?
Yes.
Roy, can you,
yes.
Okay, good. So in the midst of the Ebola outbreak in 2014, where it had taken the world 4 months to wake up to the outbreak, and finally there was a really robust response. And then I pulled back and said, well, where will we be in 3 years? And I had seen how long it took us to get going with AIDS and other epidemics, and how there's this cycle of panic and neglect. After major outbreaks in global pandemics, there's literally thousands of pages of reports, billions of dollars committed, but a few years later, things haven't changed. So I took a deep dive into the last century of pandemics and asked the question, what can we learn about preventing these? And outbreaks are going to happen. That's inevitable. As Louis Pasteur says, the bugs will always have the last word. But the spread and impact, and the main lesson is, has a lot to do with human action or inaction. So if we look at the question, where are we going with COVID-19? I mean, there are really 3 basic scenarios and a mix of those. If we let it go, we get herd immunity. Vigilance is what we're doing now. And it's really clear that herd behavior, that is all these personal protective habits that Tom Frieden talked about, workplace adaptation, lockdowns, those have worked. I mean, we know what works. And hopefully we'll have a vaccine. Things are actually very promising on that side. But looking back at the lessons of the last century, we came into this vulnerable. And as Dr. Rao said, the leadership has not been consistent around the world. Our systems weren't strong enough, and we come into it in a place of weakness. There are some really strong elements, though. We are seeing at the national level some very strong leadership in a number of countries. And just as another example, on the innovation side, we're seeing a whole new generation of tests coming in. So there are a number of different elements that can go into a really successful response. But the key thing is so much of it depends on human behavior. And so when we look at the pandemic cascade, the direct impact on people, the aversion behavior, and this cascade of health impacts, social impacts, and so on. And I'm glad it was pointed out by Tom Frieden that it's a false choice, save the economy or save lives. The reality is that pandemics kill three ways. The virus kills, we see that. The disruption of healthcare kills just as much. We saw in Ebola as many deaths from AIDS, malaria, and all from disrupted health systems as from Ebola. And the other thing is economic disruption itself kills. We know from the 2008 financial crash where there was no pandemic, but maternal mortality went up significantly in low-income countries. Infant mortality went up, child mortality went up. And in Europe and North America, at least 250,000 excess deaths occurred just from disruption of cancer services. So when we think about how to really contain this pandemic and minimize the effect, we really need to think about how we adapt so we keep health services open. We deal with people's concerns about going to healthcare. We've seen a drop everywhere in seeking basic primary care. And this is where testing comes in really important. We have a whole new generation of tests. The typical tests that we've had for diagnostics are ones where you draw it one place, you send it off to a lab, the results come back. We're seeing here where we're having an overload of the testing system in the US, 7 days wait or more, the test is useless. We have a whole new generation of point of care, rapid turnaround tests, not quite as sensitive, but being able to deploy an 80% sensitive test widely, you can get 8 out of 10 people who are affected out of the risk pool and all. And so testing is an important part of both finding the virus, assuring people when we're testing the health workers and all, that the healthcare is safe, and also workplaces. The other thing is we know that pandemics reveal and amplify inequalities, and there's higher death rates among the poor and vulnerable, economic impact. So these are the things that will determine really how we're able to mitigate the effect on the most vulnerable. Dr. Rao pointed out that we've not had a UN meeting of significance on this. And what we know from pandemics is it's got to be a whole of society response and bringing everybody together. You can't, and this is a thing that drives different parts of the community crazy. When we have the public health community needs to work with the business community, needs to work with civil society, because it does need to be a whole of society response. We saw that in West Africa when it was just run by, the response was only the health sector. It didn't work. Once it was at the national level, a response team that had all of the different parts of society working together, then they were able to coordinate. The other critical thing is communication. Our only defense now is human behavior. So we really need to be sure that folks are on board with the key messages. And one of the key things is that messages evolve with the pandemic. The other is the whole importance of trust in the messenger. So there's it's not a matter of just blasting out the message. We really need to, on the social media side, bring in influencers of different generations and bring them on board and realize that this backfire effect, people who hold tightly to a belief like vaccines don't work, they're not going to be convinced by more facts. It's going to be somebody who they trust who is giving them the message. So that's a key part. So will COVID-19 ever go? I think it's pretty clear it's gonna be with us. The question is, can we tamp it down so we minimize the deaths and the impact of the virus itself, the disruption of health services, and the economic disruption. And I think that's really the way forward. Thank you, and back to you, Roy.
Thank you so much, Jono. We could speak to you forever, but unfortunately we do have to stick to time. So thanks so much. Veronica, over to you and the next section, which is the collision of the worlds, personal and professional.
Yes, I'm really honored, and I feel like I'm in a very special place to be able to introduce two clinicians who are at the front lines of our global fight against COVID-19, but who were also infected themselves. First of all, let me introduce Abhishek Swani. He is an assistant professor at Oakland University, William Beaumont School of Medicine in Rochester, Michigan, a frontline nephrologist. And he has experience in the field of medicine for more than 17 years. So he did graduate from Sardar Patel Medical College in Bikaner, Rajasthan. And he also went to the All India Institute of Medical Sciences in New Delhi. But first of all, Dr. Smriti Bajpai Tiwari joins us, and she is in India and is an associate professor of medicine at Faith GS Medical School College in Mumbai. And speaking to you both, I wonder if you could talk about how the impact of having been infected yourselves has affected the way that you carry out your jobs at the front line of medicine, working with this disease and other people who've been infected with it. Dr. Smriti, to you first.
Thank you, Veronica. I hope I'm audible.
Very good.
Okay.
Very good audio.
Yes, fine. I really thank the organizers for giving me this opportunity. As she said, let's come directly to the point. We are running a little late. How has being affected with COVID affected me as a clinician? Now, this happened somewhere around the end of April and beginning of May, when I was infected with COVID, while I was actually rounding my patients of COVID in KM Hospital. And we know that Mumbai has been the epicenter in Mumbai from the very beginning about the COVID. So I was taking due precautions as per the SOPs. So my PPE was in place, my N95 mask was in place, but unfortunately, as we know, this is a very, it's a very crazy virus and a very smart virus. So it captures you when you feel that unaware. So it just captures you when you're not even aware that it will hit you. And that's when I got infected. I was checked for it, screened, and by God's grace, the only good thing which happened into all this was that I was a mild case. I never developed hypoxia, but I had the typical symptoms like loss of taste, loss of smell. That was pretty, high, as in I was having no taste and smell for almost a week, almost 2 weeks, I should say. Absolutely nothing. I have felt this for the first time. Mild cough and cold, and a very atypical symptom of a chest tightness and pain. So this is to put up my story. But there's a whole lot of another things which goes on when you are infected and when you're a professional, and how it affects your personal life as well. Now, I live in a household which has 2 small kids. I have twins, which are 15 months old. I have elderly patients who are high risk category. I have a mother-in-law who's sick with a degenerative neurological disease. All this coming was like a roller coaster to me. I had 9 people. Because of me, because of the high infectivity, all of them were infected. So all 9 people in my family, including my 15 months kids, were corona positive. COVID-19 positive. As I say, by God's grace, all of us were only mild cases and we recovered completely, all 9 of us. That's my personal story. I would like to say that this was a great learning experience as far as a physician goes. We see patients every day in and out. But what COVID infection taught me was that first, healthcare workers are not invincible. So please, we tend to think that, I'm taking precaution and, I'll not get infected and, nothing is going to happen to me. No, we are not. We are human beings. We are as vulnerable as the general population. So it's very impossible. It's very, very important that the PPE SOPs have to be strictly adhered to. The second thing which I learned was that as individuals, as a professionals, we are a privileged society. We are a privileged individual, no doubt. But then we are also the members of the society in large. And so when we go to our professional lives and come back again to our personal lives, we expose our near and dear ones, our kids, our family members, like we do, and we can spread infections to them. So it's very important that when we talk about public health at large, we don't exclude ourselves as professionals and think, okay, so this is only for the public and this is not for me. It's not. I'm a part of the society as well. And so I have to adhere to those norms as I've been telling to other people. And the third important thing which I would like to state is that working as a team is very essential. And when I say working as a team, I mean not only at professional level, but at personal level as well. So we have this close-knit family system in India, which has friends, family calling to us, talking to us. It helps a lot. And I have seen that with myself in this COVID-19 situation, where a lot of mental stress, the financial stress, the social stress, all that, if it is shared, if the responsibilities are shared between the family members and also your professional colleagues, it really helps you. It really helps you. So these are 3 key elements I would like to state from my experience getting infected and also treating my patients. Thank you.
Thank you. Dr. Sruti, we'll get back to you because we have a full 40 minutes. And with you, you were talking for about 3 4 minutes. But first, I'd like to ask Dr. Abhishek in Michigan to talk about what his personal experience and his initial thoughts.
Thank you. I'm Abhishek Swami. So I'm a nephrologist here working at Michigan, as you give the introduction. So I'll get straight to the point. I wanted to highlight both. Can you hear me? So I wanted to highlight both sides of the aisle. And as a physician, we saw that world map where America or USA is colored red. And so we were hit pretty hard, globally speaking. Michigan got hit hard around March, right after New York, and was one of the top hotspots in the world. So we had 94,000 total cases so far. We've had 6,000 deaths. So as part of the large tertiary care hospital here, the hospital got hit hard really, really bad. And our ICUs were full. It was the ICU, the patients were spilling out of the ICUs. Wards were full of COVID-19 patients at every level of severity. And we saw a lot of suffering. So I'd like to first start, typically in our hospitals, as all the doctors are aware, hospitals are bustling with crowd, there are visitors, you've got cafeterias, you've got, concourse that look like malls. And so there's a lot of activity, and suddenly everything changed. So for us, all that the lively environment evaporated, became quite gloomy, right? So no visitors, nobody was allowed. The colleagues, doctors and nurses were all geared up head to toe. You could just see their anxious eyes, as you pass through. People were scared and anxious. So that kind of the environment changed in a big way for us. And the doctors were scared and anxious, rightfully so. And initially, because it was early part of pandemic, we didn't know how to deal with it. We didn't know, do we wear surgical masks? Do we wear N95s? Do we wear masks in the hallways, or just when you go into the patient room? Is there aerosol generation where people are being intubated? So it was a dreadful situation. And then as physicians, as nephrologists, we did get pushed to the front line because there was a very high rate of renal failure. So we had to dialyze these patients in the ICU. Up to 60% of the patients got kidney failure and had to be started on a lot of forms of dialysis. We started to get stretched thin because we were running out of machines, running out of solutions, and personnel, technicians to run those dialysis. Personally, we lost a dialysis technician to COVID when he was pushing machines into the rooms and setting them up. A bunch of nurses got sick early. Physicians were started to get sick. And as you walked into the patient rooms, the typical, what we've learned through medical school, the doctor-patient touch or the healing touch that we call disappeared because we are gloved, they can't see our faces, we are in PPE. So that was scary for the patients, and they have no family members to come and visit them. And the only thing that is the TV blaring in the background. And all that had was the pandemic news, which was depressing. So the patients are lonely and scared. You know, they would tell us, doctor, please save me, because they're hearing what COVID does and they know they have it. And so these were long days. And then when we would get home, we were really scared to bring the virus home because I have 2 kids. My wife is there. Fortunately, no elderly parents at the house at that time. So I would have to change or actually take off my clothes in the garage, run straight to the shower, and be very careful. And at the slightest cough, I would get scared and I would be checking my temperature. And so that fear was always there. And some of my colleagues took the extreme step of staying in a hotel because they would work 10, 12 hours a day here, not even go see their family. So extremely tough period for physicians. And then, you know, what I was dreading happened. I got the virus. So obviously fatigue set in. I thought it's work. And then, you know, once when I checked my temperature, it was high. Immediately got tested and it was positive. So again, fortunately, you know, what I experienced was severe fatigue, complete loss of smell and taste. And so Scotch tasted like water. I had dry cough, some shortness of breath, but fortunately no severe pneumonia. I recovered at home. My symptoms mostly lasted for about a week. I had to isolate myself from the family, quarantined for a couple of weeks, didn't go out, didn't go to work, obviously. And from the support of my wife, her exemplary strength, she was scared too, but I recovered pretty well. So this is what I went through.
Yes, Dr. Abhishek and Dr. Smriti, you know, we have about 4 minutes left to discuss, to ask you both a follow-up question, and it's the same one about your impression of the effectivity of public health policy with regards, from your perspective as doctors and as former patients. And by the way, I'm so glad that you're both better now. Dr. Smriti, is she still there?
Yes, I'm there.
Hello. Wow. You could talk about the Indian perspective as well, and we'll ask about the US perspective from Dr. Abhishek.
As far as the Indian perspective goes, I would say, you know, we are a resource-limited country with a huge population. Those are our biggest challenges, I would say. So whatever hard work we put in, you know, our numbers sort of dilute it most of the time as far as the public health goes. This is what we have seen with respect to AIDS pandemic. We have also seen with other infectious disease. We grappled with polio. We have grappled with lots of other infections as well. You know, so for us, when COVID hit us, you know, we were scared from the very beginning. Mumbai being the epicenter, and we have this issue of population density here. So from the very beginning, I would say our governments were very cautious. You know, somewhere I would say compared to other pandemics, to other infectious disease, the response this time was a little much rapid and much intense, so to say. So that is something different, which I would state as compared to other people. We were expecting worse. Let me tell you very frankly, we were expecting worse because we as big population, when things hit us hard, with resource limitations, with a lot of population dependent only on public health setups and private hospitals charging much. So all these were our issues, but our government stood up, even general population at large. I would say relatively compared to other situations, we have actually been able to manage situations better. We did suffer, no doubt about it. But if you compare with other, resource intense populations like US, or for that matter, the entire Europe, you would see that our mortality has been less compared to them. Even we were able to balance stuff. So public health, at least this time, as far as the COVID-19 goes, somehow we have been able to manage better compared to other people if we compare. But it's not the best, as we would say. It's not that, we are doing everything perfect. It's not that we are not losing people. I'm not saying that. I'm not saying that. But we were better this time compared to other pandemics which we have faced in past, or we have been grappling with throughout as far as the infectious disease goes.
Okay. I know that Roy is probably listening closely to what you're saying because his elderly mother lives in Mumbai, and I know they've just gone under lockdown again, haven't they, Roy? Dr. Abhishek, what's the situation in the US? There's a very interesting comparison made there between the resource rich and the resource poor.
Yeah, very good point, Smriti. And unfortunately, I think the US response and the way US is tackling this pandemic is less than ideal. First, I'll talk about Michigan State, where I live, which I think did a very good job because it was second only to New York in March and early April. And then we really flattened in the state, we flattened the curve. In the hospital, we had more than 600-700 people in early April and March. Now we're down to about 15 to 20. So that tells us that, community-wide spread has gone down. The local government did well, and public health officials did well. But as a nation, I think we are struggling big time. And then, a lot of states right now are hotspots, especially southern states. It's ripping through the country just like a wildfire. Still, and being very resourceful country, a rich country, I think the lack of a central policy probably has affected us in a bad way. And there's a cultural, a pro-choice feeling amongst a lot of people where the anything that's mandated is not taken as, and the lack of distrust and the lack of trust actually with public health officials has affected us.
It's a real problem. All right.
Yes.
Thank you very much, Dr. Abhishek. I'm sorry we're behind schedule, so we're going to move on. But honestly, again, we could have spoken to both you and Dr. Smriti for much longer. Thank you very much indeed to you both.
It's an honor. Thank you.
All right. Moving on to our next speaker, Mohammad Rashid will be starting off this next section. We have 5 speakers. It's the biggest global challenge since World War II. Governments and societies respond. And Dr. Rashid will be speaking about the experience of Afghanistan as the senior advisor, HSS COVID-19, to the Ministry of Public Health, Afghanistan. He receives his education here in London, apparently, at the School of Hygiene and Tropical Medicine. Good to have you on board. Can you tell us about your perspective?
Good morning, good afternoon to everybody. I think among the panelists, only John knew me that, I'm a frontline public health practitioner since the last 3 decades I'm working with within the country. I will start my presentation showing 2 different data. Means that the capacity of the health system for detection and management of COVID-19, and also a survey conducted recently. The current, update for COVID-19 is that we performed around above 90,000 suspect case has come to the public health facilities, and 37,000 confirmed cases we have, which 25,000, 26,000 are recovered, and around 10,000 are active cases. And the total case per 1 million population based on the DHIS2 data of the public health system is 950, which that is conducted, it is above 2,000 for 1 million population. And the next, can we go to the next slide, sorry? Hello? Hello?
Can we have the next slide, please? Whoever is handling the slides, thank you.
Yeah. I don't know, I'm not handling this slide, so I think.
Okay. Yeah, we recently conducted this zero prevalence survey at national level. We covered all, divided the country in nine regions, and we had 360 clusters with almost around 5,700 households. And 82% of these households, attended this survey. It was a cross-sectional survey. We aimed, to do interview and at the same time do, rapid test to the, attendance. And we selected 2 persons per family, one from 5 to 18 and the other one from 18 to, above. And if you see the result of this prevalence, for example, for over 5, it shows that, we have around almost, big prevalence in the cities and lower in the remote areas, and mostly in Kabul city, in border to Pakistan and border to Iran, we had much higher, cases in those regions. And the total, the total prevalence was around 31.5% for the country. And while we see the prevalence among, different, ages between adult and children, we see that, above 35% of the adults are totally infected, and the children are 25%.
Doctor, Doctor, I'm sorry to interrupt. I'm just absolutely astonished. Is this right? 53%, more than 50% prevalence in
yes.
Everyone over 5 in Kabul. So 1 in 2 people is infected.
Yes, that's right. Yeah, I'm going to present, then we can discuss. At this unfortunately, that we had a huge community transmission all over the country, despite, because the capacity of the health system was not much, to stop the community transmission. And we had millions of returnees from Iran, from Pakistan, with active cases. They came, they went to countryside. And this was, the biggest reason, for community transmission. And the prevalence among, location, while we did this survey, there is quite a big difference between rural and urban. And for urban, we had 42, 42% or 30% for adult and children, while for rural, we had 31 or 23% infection for the children. And at the same time, while we divided, analyzed the prevalence by sex, unfortunately, due to cultural issues, due to some other, hypotheses, the prevalence is much higher in female versus male. But this is a very preliminary data, and we are going to further work. We will see that, how it comes. And still, the preliminary data shows that, there is higher in female. And the conclusion of this survey showed that almost less than 1% of the cases are detected and treated by the health system, by the public health system. And the finding shows that, totally countrywide above 30% of population infected, and the infection is higher in female than male, and also the infection is higher in concentrated population in cities, and then the rural areas. At the same time, infection is higher in adult than children. And we did this test by IgG and IgM, and we did some verification by ELISA, but it is not covered because we face the shortage of ELISA, and we are planning to do it.
Dr. Rashid, I know you have many more slides to go through,
Yeah.
but I'm afraid we're a bit short of time, and we're running behind. So I wondered if I could ask you a question about the Afghanistan government's response. It's clear that you have a very serious situation in terms of the rates of infection in a resource poor environment. And we haven't even mentioned that you are a country at war, singularly in the world. That's a very unique and difficult challenge for officials like yourselves. So you have to commend your action. What can possibly be done in this situation?
Yeah, the current slides show what we did. The first we had big failures and the huge nightmare in the health system response, toward the COVID-19 pandemic. Because of this, Ministry changed his policy, and we said that all health system, primary and tertiary, secondary care should be responding. Also, we involved private sector in case management diagnosis of COVID-19. At the same time, we changed the case definition from the laboratory, diagnosis to the clinical sign and symptoms. And we developed very, simple policies and strategies, protocols countrywide. We applied for the public and private sector. At the same time, we introduced, we pushed the contact tracing, and also for the mild and moderate cases, we involved the communities to do home-based care. The families or the country should take care for their mild and moderate cases. This was, the strategy mostly used, for the country. At the same time, we, through the health system, we contracted out, the ICUs for, severe and critical cases, the whole country. We involved, at the beginning, we had few hospitals, few special hospitals. Then we decided to scale up to all provinces. In each province, we established ICUs, we established isolation wards, at least to decentralize, the system. At the same time, the response should be in the peripheries. Oh. And the ministry decided, to do, quick inventory of the overall warehouse and central stock of the ministry. Above 70% of the equipment, supplies, medicines, any, consumables were distributed to countryside to have a better response, to the pandemic. At the same time, we changed, the reporting system. We digitalized the system that, on daily basis we were receiving report, and the ventilator, CPAP were distributed. People were trained to use it. And also, we had just one lab, functional lab in Kabul, and fortunately, with the support of international stakeholders and WHO, other, national stakeholders, we scaled up this lab to the, peripheries, to the regions, and right now there are around 20, active lab doing. We increase the testing process.
All right, I'm awfully sorry, Dr. Rashidi. I'm afraid I'm going to have to move on and hand it over to Roy, just because the time is so short. But it sounds like we could have spent the whole 2 hours talking about Afghanistan. You have some serious work to do. Very much congratulations on what you've managed to do so far. Good luck.
Thank you very much. Thank you. If there's any question, I would be, you can share the slide. I would be available. Thank you.
Thank you so much. So now moving on to the experience from India, we've got Dr. Samiran Panda, who actually straddles the worlds of HIV and AIDS, because he's at the forefront of that program. And now he's been deeply immersed in COVID-19. So Dr. Samiran Panda, what has been the experience from your perspective from a country that's been hit pretty hard? Over to you, Samiran.
Thank you. Can you hear me?
Yes, loud and clear.
All right, thanks. In the best interest of time, I would try highlight what has gone well in India and what could have been better or we need to improve upon. But if one is interested in knowing in one sentence, how is India doing? I can even do that. We have started sailing on a ship, and the ocean is quite rough and the weather is stormy, but we are still surviving. And the ship is not yet built fully. We are in the process of building it. So in a way, what I'm trying to say is that we started pretty early. When even the first case of COVID-19 was not detected in the country, India took certain public health measures in terms of advisory, bringing in restriction to travel, and also the thermal screening at the airports and the seaports and the land borders with other countries, which is quite an advanced step in terms of knowing or keeping track of what's happening globally and what we could do. The other good thing that happened as an early response in India is to impose national lockdown when the total number of cases was even less than 500. And that happened in the end of March, and the number of deaths was less than 10. But these were like early responses, and I see a striking similarity between HIV epidemic that was controlled in India, and there is a success story, and COVID-19. We started national serosurveillance for HIV when the first case of HIV was not detected. There was not even a single case known in the country. So from that perspective, there is a similarity. The other things that went well, people have access to the mass media and enough information. But as I'm with the Indian Council of Medical Research, I would try highlight some of the issues that might not be that well known to the world. Right from the beginning, there is a close collaboration between the Ministry of Health and Indian Council of Medical Research. So the research findings kept on informing the public health programs, which is a good thing that happened. And it's not just the Ministry of Health, but for example, Ministry of Textile, because we required huge number of swabs to be produced for testing. But as Mr. Prasad Rao said, all of these were directed towards medical model of knowing the epidemic. So in order to know the epidemic, we had to have our test and track and treat model functioning or working. In that count, we not only did the laboratory scaled up services very well, which is now 940 all over the country. And also there are groups, the task force created and the clinical research groups created, epidemiology and surveillance group created, as well as the operational research group under Indian Council of Medical Research. So all these groups meet frequently in order to inform the public health programming. So these are something which I would highlight as things going well. The things which could have been better is certainly in terms of the people's involvement to deal with the people's health. There are innovative examples from the eastern state of West Bengal where the COVID survivors and the COVID warriors, they have championed the cause of reducing stigma, but that has not scaled up to an extent the way it should have happened for the country. Moreover, when we talk about the total burden of infection in India, 80% of it is restricted within the 10 states. So the states are very heterogeneous and there is porous border between them. So while some of the states have started witnessing success stories, but we really don't know how the epidemic is going to unfold in other states. So there's a great deal of necessity in terms of learning from each other. So the cross-learning between states are not happening with the speed that one would expect it to happen. Thirdly, and the most important, is in terms of the other health needs, which are really suffering. I would give you two examples. One is HIV services, and the other is TB. Multi-drug resistant tuberculosis was an issue, and tuberculosis per se. But the enrollment in the TB detection centers and linking up with the treatment clinics and the facilities have really reduced drastically. So what all I'm trying to say is that it's not only COVID, well, of course, it's true for all the countries, but it is really impacting negatively, and how would the health system in India would cope up with this is a big, big challenge. So in short, what I would say that the beginning went very well. We started acting pretty early and pretty fast. But then as the epidemic unfolded, we could also have a collaboration between the public health program and the Indian Council of Medical Research, which informed the epidemiological surveillance, the clinical groups regularly updating. Moreover, there are advisories which are evidence-based. So it's not just in-country evidence which we looked up to, but the global knowledge and the global evidence. We drew upon that. For example, if there were systematic reviews available, meta-analysis available, based on those information, we were regularly updating our clinical management guidelines, and also how to protect the healthcare workers. That was a big issue, and there was a debate about hydroxychloroquine usage, and we generated the local evidence, which actually helped the formation of the advisory. But what really did not go well is in terms of the lockdown, and then the migrant laborers moving with the intention of going back to their native state, and then a great misery that they faced. So we could have been done better there. And the whole issue is about no state should be left behind, because health is a state subject in India. So naturally, the state has to take responsibility for managing the epidemic. But if it is not managed well in one state, naturally it is going to have impact, or it is going to impact negatively on the other states. So I will stop here and would basically say that while the public health interventions worked, particularly imposed or implemented by the government, the sustained behavior change, which is expected or which needs to also happen in great deal or in great proportion at individual level, that campaign and involvement of people to achieve that sustained behavior change is yet to happen at a level where we could expect the prevention to work until and unless we have an effective vaccine. And lastly, but not the least, is a listening exercise that we very recently undertook. That's an international symposium on vaccine development, and India is now in with the full effort of developing indigenous vaccines, as well as accessing the global knowledge and getting into partnership with Oxford and other universities and academia, so that the vaccine preparedness is there in the country. Thank you.
Thank you so much, Dr. Panda, for being so candid about both the good things that have happened, but also the many challenges. And it'll be, I think, truly interesting for India to document all of this going forward at a suitable time so that we can all learn from it. Veronica, over to you.
Absolutely. Thank you very much indeed, Dr. Panda. To introduce now our next speaker, Dr. Arvind Mathur is currently the director of a recently launched project, the Asian Center for Medical Education, Research and Innovation. The organization aims to work for improving health by imparting medical education, conducting research on relevant health issues, and developing innovative ways of improving healthcare delivery, particularly for older adults. And that's why his theme is leaving no one behind, supporting the elderly. We should say, of course, that Dr. Mathur has been involved in medical issues and teaching for the last 44 years. Thank you, Doctor.
Thank you, Veronica. I think the older people are most vulnerable, as has been mentioned earlier also by Tom also. They are the one who are vulnerable on account of various reasons because of their health issues or the immune status itself. But the other issue is about their care. And this has been shown very well in the long-term care facilities, which had the worst brunt of the epidemic. And that has highlighted the issues of the infection control practices in long-term care facilities, both for the residents, for the visitors, and for the caretakers also. So I think this is one issue which needs to be looked into. Herein, I'd like to highlight that the worst was seen in the West about the long-term care facilities. But in India, we did not have that much of effect in the long-term care facilities because our long-term care is primarily a community-based care. It is not in the institutional-based care. So the institutions, they had the worst part. Now in community, during this COVID time, what we have observed for our patients and for the older adults in community, that they, besides the fear of the disease, they have suffered on account of inaccessibility of the healthcare facilities during this particular time. And the other thing is that their social isolation has also been causing trouble to them. I think with the digital knowledge which is being imparted to them and the use of the digital media has helped them, and certain measures which have been taken by the health organization, the public health hospitals, of providing a doses for a longer duration to these persons, institution of the telemedicine in India, that has also helped us in communicating with these patients or so. I think they would also need to be looked at by their family members, youngsters who take care of them, because they have to be aware that those youngsters who take care of them, they could also transmit disease to them. And that's why the evaluation of the caregivers is also important for them. I think I'd like to highlight that the older people are vulnerable for this particular infection. They need a special care, particularly the provision of telemedicine, provision of a special information to the caregivers, and institution of infection control practices is also essential for them. Thank you.
Thank you very much indeed for bringing much needed spotlight and attention on the situation facing older people. Thank you, Dr. Mathur. Now over to Anil to introduce our next two speakers.
Hi, thank you, Veronica. I would like to introduce you to Mr. Atiq Mohammed. Atiq Saab, aap hain? Aap sun pa rahe hain, Atiq Saab? Can you hear me? Atiq Saab.
नहीं सर उनका connection lost हो गया है शायद. I'll just call him.
Okay, that's okay. All right, so we'll move to next one. We won't waste time. Veronica, I think you could take over, and if he comes back, I'll take over. He's lost his connection.
Oh, I understand. Okay. Thank you very much indeed. We're going over to Brigadier Mahendra Kumar Garg. Thank you. Are you there, sir? Brigadier Mahendra Kumar Garg.
I'm there. Veronica, I'm here.
Okay, fantastic. Glad that you're here to pick up the ball at this point. Just to introduce the Brigadier is Professor and Head of Department at the Department of Medicine and Endocrinology at the All India Institute of Medical Sciences. And he has a very learned background in his approach to the situation that is unfolding in India. Would you like to speak about how the IIMS Jodhpur has responded to COVID-19?
I think his video is turned off.
Yeah. Are you able to hear me?
Yes, we are able to listen to you, but we cannot see you, sir.
Don't worry. My voice is loud. You don't have to listen, see me. Yeah. So firstly, after all the public health prevention measures, the patients have landed up to my aims, and we have to do something. And as you rightly told, it is World War II to COVID-19. And to win a war, we must know the enemy. And here, enemy was unknown. So how we can win the war? Either you know the enemy or we make ourselves strong. That is the only two ways to win the war. So once we never knew the enemy, whole world was acting as a detective. All the information by all the academicians given to us for the information. So we first set up a Corona war room, army way. So what we did was we set up a Corona war room where our director was the chief, and we have all the departments, including laundry, dietary services, engineering services, anesthetists, myself, everybody was the part of that war room. So that a system was developed how we are going to fight a war against the unknown enemy. So first was setting the war room, which will decide about the policy, gather the information, develop a SOP, train the manpower, and it is a continuum process. We meet every day to change our policy according to information poured in by the world literature. Once we set up that was the system. Then with the space, we had the 6-story building. So we developed the first upper 3 stories block as a Corona ward. So Corona ward was totally separated from the normal patient, which should not be deprived of the care. So the below 3 floor was the normal care, upper 3 floor was the Corona, where only Corona patient can go and healthcare worker with PPE can go. Nobody else was allowed to go in that area. So that was the space. We created a positive, because our is the central AC system. We talked with the engineering populations and we developed a system where we can create, or we can have the exhaust or something, block something, I don't know their specification, to according to the international literature, we could create an environment for the patient which is safe and for my healthcare worker. Third was the staff. Staff, as everybody told about the fear, we have to remove the fear. If you have the fear, you cannot fight the war, you cannot win the war. We have to take it from the fight. When you have to enemy, if you win the war, there should not be no fear in anybody in my healthcare workers. So how we can do it? By training.
Robert, hey.
Yes, sir. Am I audible? Yeah. So how we can win the war is train. So for the healthcare worker, as Jonathan and everybody pointed out, there is a fear among the population. We have to remove the fear. Who will remove the fear? We. If we fight from the front, we will win the war. So I told, when I was giving the lecture, one person asked, how I can prevent the Corona from being affected? Manka, only way to win the Corona is get infected with the Corona. And then nobody can attack you. You are prevented. So that is the way you have to decrease the fear. So training of the staff. Second point, very important, everybody brought out, and from my colleagues from India also, they got infected. So how to prevent my healthcare worker from getting infected? That was the very important. How to give the better care to every patient coming to the hospital, irrespective of the Corona status. As Jonathan has pointed out, that healthcare was deprived, many mortality has increased. How to prevent that? So for the staff training, we have the rigorous training in the March for the doffing, donning, all the SOPs, all the way we are going to deal from the housekeeping staff to the doctor. They all were trained together. Nobody should feel the doctor was trained better and housekeeping staff was trained less. We combined housekeeping staff, nursing, ward boys, doctors. They were all trained together for the SOPs, for the disinfection, for the donning, doffing. Every part was trained by our professionals to each one of things was trained before it was started. In the hospital, because OPD services was closed, because there was the OPD was the place where it can infect many of the persons. Only emergency was allowed to be open. So every patient, what we divided at the emergency, we created a screening desk which will divide the patient in the corona positive suspect or non-suspect. Non-suspect will go to the usual care. Suspect, we have created a ward where they will go, where ICU care, normal care will be provided irrespective of the corona status. So no patient was deprived of the treatment for any condition because of the knowing corona status or not. Once corona status were not, they were taken the adequate care. So staff, second problem, everywhere in the world, when my duty will come,
Brigadier,
when I will go to the duty.
I'm going to have to ask you to wrap up in a minute. We're just over time.
Yeah, I'm wrapping up. So what we did, if our whole staff in the last 6 months, not one doctor was repeated duty. Up to September, we have created rosters circulated to all and given due consideration to all the staff so that they can do the duty once in 6 months for 15 days. They were pre-informed. All the accommodation, food, everything was taken care of in those 15 days. So that was the staff and supplies that somebody pointed out. We created our own supplies. We created a unique PPE, which was disinfectable. We contacted the corporate sector. They manufactured the PPE for us. So we were adequately supplied. So system, staff, space, and supply. We created and we are fighting. Till date, we have 50,000 screening, 1,600 patients positive, 1,200 admitted, only 60 died, only 10 healthcare worker was infected. That is my success story.
Congratulations, and thank you very much for letting us know about the response of the AIIMS Jodhpur, Brigadier Mahendra Kumar Garg. And now to wrap up, over to you, Anil.
Thank you so much, Veronica. I think all the panelists were great, and I'm sorry Mr. Atiq Mohammed could not join. And in the interest of time, we will not have a summary session today, but everybody will be getting the reports from us for you to review, and I think it will be published widely, and the recording will be available widely. So thank you so much for that. I also want to be very, very specific and clear. All these panelists here, most of them have come with HIV AIDS experience, and that experience has helped a lot in controlling COVID-19 as much as we could. And going forward, that's going to help. It's a very different pandemic, different tales, different stories, but I think the experience has helped us. At the beginning, people told me that these are different epidemics, these are different pandemics. How are they going to help? No, our experience, all of us who are on this panel, or most of us, I think that has really helped. And I cannot name because every single person here involved has been affected by COVID-19. Sadly, every webinar I have, I can report either there is one death or one is about to die. The last 3 weeks I've seen, and that's really sad actually. So we have learned from HIV AIDS, and we are going to work more towards controlling, curbing, having these kind of webinars, panels, and I think the mission is same, the goal is same. So thank you so much, Roy and Veronica, for moderating this wonderful session. We could not have done without you, and the time management, what you have done, I could not have done actually. And over to the Honorable Vice Chancellor of Poornima University for the closing remarks. And I know you always brief to the point, so over to you.
Thank you, sir. Thank you for giving me this opportunity. And opportunity more to me because I could speak in this such a galaxy of intellectuals. And if I see nobody is having, they all are authority in their own field, own subject. And this journey from AIDS to COVID has given me a lot of knowledge personally, a lot of learning personally, a lot of new thought personally, and it has given me also a perspective where the India is today and what the people are doing for our own country. I am grateful to each one of you for sharing your thought, and I am very sure your thought-provoking speech and the knowledge-sharing session may have given many, lesson, eye-opening lesson, and they may be having a very their views or the horizon may have expanded. Once again, I'm grateful to all of you for sharing your views. particularly to Anil Purohit.
Thank you so much, everybody. This is not the end. It's the beginning of this panel, the work we all do. And I'm sure we'll convene again on these panels and maybe physically in Jaipur or Jodhpur when the world opens. Thank you so much, everybody. Rahul, to you.
Thank you, sir. Thank you very much.
Thank you, everyone. Can I just see your hands and please wave so that we can have a group picture? And please turn on your videos so that we all can see you. Thank you so much.
Smile also.
Yeah. Thank you so much for joining. And here we go. Say cheese.
Cheese.
Well, thank you. Bye-bye, everyone. See you.
Cheers, everybody. Be happy and be stay fit.